Good evening all. Welcome to ISA online PG class. Today we have got a very eminent teacher, speaker, teacher of teacher, guide, and above all, a very nice and gentle human being, Professor Baljit Singh sir. Sir will be sharing with us his knowledge and expertise on a very important topic pertaining to spinal anesthesia, that is bony hits during spinal anesthesia. It's my honor to introduce sir to all the students and the faculty. Sir right at present is Professor and Head Department of Anesthesiology, HGT Medical College, Gurugram. Sir has held various positions of Indian Society of Anesthesiologists. He has been Secretary of ISA Delhi for 3 terms. He has been ISA National Governing Council member and Vice President of ISA National. Sir is on different societies and associations. He is member Board of Directors of ICHA. He is trustee and CEO of ICA, Indian College of Anesthesiologists. He is editor-in-chief of Indian Journal Health Sciences and Care and is convener of Specialist Board of Anesthesiology in National Board of Examination for Medical Sciences. He has got more than 170 national and international publications in reputed journals. And if we talk of presentations, I think they will go in thousands. It is pleasure, sir, to have you with us. And we are very lucky that the students will be knowing about this important aspect of bony hits during spinal anesthesia. I'll request Dr. Ankur Khandelwal and Dr. Nishant Sai to carry forward from here.
Thank you so much, sir. A warm good evening to all the respected senior faculty members, delegates, and postgraduate students. It's been an absolute honor and privilege to have amongst us today Professor Baljit Singh sir, who will be discussing on the topic bony hits during spinal anesthesia. Nevertheless, he has this vast experience of being an anesthesiologist and an eminent faculty. And I would also like to congratulate the ISA National to successfully conduct these webinars every Monday. And today is the 41st webinar, which is also being streamlined live on YouTube. And the video recording will also be available in the ISA website. So without wasting any time, I would now like to welcome Professor Baljit Singh sir to begin the session. At the same time, I would also like to remind all the postgraduate students that if you have any queries, please do type your queries in the chat box. We will take all the queries at the end of the session. Thank you so much. Over to you, sir.
Before sir starts his talk, I'll request Dr. Giri to President ISA National to say a few words.
Thank you, Naveen. It is a pleasure to hear Dr. Baljit ji today, and I thought bony hit, I also should hear that, and so because left and right gives spinal daily, and let us know that from horse mouth, what is this bony hit and how we have to go ahead and all. It will be enjoyable and it will be a great talk by you, sir. Yes.
Thank you so much, first of all, Dr. Naveen Malhotra for the very kind words, and of course to Dr. Venkat Giri for giving me the honor, along with Dr. Naveen Malhotra, to join you this evening and share whatever little experience I have with this. That's one. And before I proceed with my talk, I would like to compliment Dr. Naveen Malhotra for a very, very, I would say, regular ISA teaching program. This, as I'm told, is 41st continuous program that ISA is having. I think that's a tremendous service that you are doing to the postgraduate students. I'm sure they would have loved it, and certainly they would have loved you also as the organizer of these programs. Wonderful job you are doing, not only for this academic. I think overall the kind of leader that ISA needed to give the right direction and of course the thrust where it is exactly required. You are doing a great job. God bless you. Please continue doing that. I think we need few more Naveen Malhotras in ISA National. So God bless you once again. Okay, so coming to my talk, I'm going to share my screen. And there it is.
Yes, sir, it's visible.
When we are going to talk about the bony hits during spinal, I think we all have gone through this stage that when we were beginners, we ended up hitting the bone right, left, and center. As the experience we gained, the number of bony hits before we get to the CSF decrease. And I'm sure now those who have 20, 30 years of experience, they can do it in first attempt almost all the times. Whereas while we compared our incidents when we were students, the bony hits were certainly more. To understand why these bony hits occur, we must understand what is the mechanics of the needle as it enters right from the skin puncture side to the CSF that till we obtain the CSF. Now, okay. Now, what is mechanics? Mechanics is basically the science that is concerned with the motion under the action of forces, including the case in which a body remains at rest. Exactly thinking of that with this definition, there is a needle that is under the motion and it is action of the force, and the force is coming from our hand. We are trying to push that needle inside or from the side that we have selected where we want to get the needle in, and the needle is moving inside, and our target is that we must reach the CSF so that we can inject the drug there. Now, what mechanics concern? One is the application of force that is in our hand, how much force we apply. We know with experience how much force is required to be applied. The second is the direction of the movement of the needle. That also is in our hand, and the direction of the needle is in a way that we, over a period of time, we learn as to in which direction, how much angulation it should be at. When we are putting the needle in. If we are doing at the lower lumbar region, what should be the angle to the vertical from the back, and what should be the angle as we move higher up. So we learn with time, and of course there is literature to guide us. Then the next thing is the resistances that are met by the moving object. The moving object, what I mean is the needle. Needle is a moving object, and as it enters through different tissues, before we reach the CSF, those tissues which are there on the way, they change the resistance. See, when the needle is passing through the ligament, the resistance is more. When it is out of the ligament and non-ligamentous area, there the resistance is much less. And as it crosses the ligament flavum, then of course the resistance to the needle advancement is much less. Now, what should I be talking about during this talk? One is a curvature of understanding. We must understand all these things before we really know what exactly do we hit when we encounter the bone. We must know what is the curvature, how is the curvature that is relevant to the anesthesiologist, curvature of the spine, I mean. Then the direction of the needle. What should be the angle of the needle in the transverse plane, and what should be the angle of the needle in the longitudinal plane. Longitudinal means longitudinal plane is from head to the caudal area, so that is the longitudinal plane. Transverse plane is at right angle to this. And then is a difference in the angle at different levels of spine. As I told you earlier, that the angulation of the needle in relation to the spine is much less as compared to the angulation of the needle that is required at the upper lumbar or the lower thoracic region. And equally important is the point, what is more important? Is it the midpoint between the two spinous processes, or it is a midline? We'll come to more of this later on. Then, of course, the force required at different levels of insertion. So I think these are the basic things that we must know exactly when we are performing spinal anesthesia. Now, coming to the curvature of the spine, at birth, the spine of a newborn is C-shaped with just one curvature. one curvature. It is just like C-shaped, right from from the cervical region right up to the sacrum. And as the child grows at about 6 months, the infant starts lifting the head during the first few months, and this cervical curvature starts appearing. Cervical curvature, earlier it was C-shaped, now it is somehow reversing in the upper end of the spine. As the child grows further, the infant learns to crawl and stand. The lumbar curvature and the muscles also develop, and the strong muscles, they help the child to gain strength and balance to walk and run. There you can see, now if you compare the curvature of the spine at birth, which is C-shaped, now at 6 months, this child starts lifting his head, the cervical curvature comes up, and as the child stands, it's a lumbar curvature that also comes up. So there is addition to the curvature of the spine as the child grows from a neonate to about a 1 year. So this is the adult spine, as you can see. In the upper end, you have one curvature which is, convexity forward. That is the cervical spine. In the thoracic region, you have the concavity which is facing forward, and in the lumbar region, you have the convexity facing forward, and of course in the sacral region, again it is a concavity that is facing forward. So there are, in a nutshell, there are 4 curvatures of the adult spine that we can see of. Out of these 4, 2 are primary curves. And primary curves are those which are congenital. That is the thoracic and the sacral. These 2 curves are the original curves which were there in the full C-shaped spine which was present at the time of birth. So thoracic and sacral are the primary curves because they are present right from the birth. The secondary curves which are acquired, that is cervical. When the child started, it starts happening right from the moment the child starts lifting his head, and the lumbar when the child has started walking, and thereafter the lumbar curvature also appears. So we have 2 primary curves which are right from the time of birth, and there are 2 secondary curves which are acquired, and they appear at a later time. Then apart from this, we also must know what is the high and low points in spine position. When the patient is lying spine on the table, there are certain areas which are at a higher level, and there are certain areas which are at a lower level. Among the higher levels, if we see with the patient lying supine, it is the lumbar 4 vertebra which is at the highest point. And if coming to the cervical region, it is somewhere around C5, which is at the highest point as compared to the rest of the spine in that particular region. So C5 and L5 are the high points if the person is lying supine on the table, on a flat surface. Now, other way, if you look at the low points, this is one at T5, thoracic 5 vertebra, T5, T6 it can be. And then coming to the sacral region, it is sacral 2, second sacral vertebra. So we have 2 high points, C5 and L5, and 2 low points which are at T5 and sacral 2. So these are important again from the point of view of the drug that is given to the patient. Now, if the drug is given here, deposited in the CSF at this region, you can see that it is deposited at a place which has a high level as compared to the right and left of that region. So the drug travels a bit Kevlar, and it also travels a bit towards the sacral region. So it spreads very well, and you get the area anesthetized as per the volume of the drug that you have injected and the site at which you have injected the drug. So it has a lot of relevance. Now, if you give a large volume, there you can see that the drug can even go up to thoracic 5. If you're given a large, say, drug, say, for epidural, and the head end of the patient is low, and the drug can travel right up to thoracic 5 as well. The next important thing is the angles of importance. Angles in relation to the long axis of the vertebral column. Now, before we go to that, we must understand what are the different parts of the lumbar vertebra. We all know there is a vertebral body, which is in the front, which is not a rounded one. It's somewhat oval or somewhat, I would say, a bean-like, you can say that. This is the strongest part of the vertebra, because on this is the main weight-bearing portion of the vertebra in the vertebral column. Then we have two very strong bony areas which are called as pedicles. This was where the arrow points is the body of the vertebra, which I told you earlier. And these are the pedicles that we can see, which are connecting the body as well as the lamina of the vertebra. So these are the two pedicles on either side. And the next is the spinous process, where the arrow is there. This spinous process is lying in the midline, and it projects posteriorly. And this is what we palpate when the patient is lying or in the sitting position, flexed position. What we palpate in the midline at that time is the tip of the spinous process. So we calculate which space exactly we want to go for spinal anesthesia, and it is the spinous processes which help us to put the needle in the interspinous region, whichever side we decide to go in. So that is the spinous process. Apart from that, what we have is the transverse process on either side. These are projections laterally, and then we come to the angles. Now, if you see the vertebral column on the left side, there is a dark black line in the horizontal plane. This is the horizontal plane, and then there is another line which is forming an angle, and this angle is in relation to the angulation of the spinous process in relation to the vertebral body. Now, this is the angle of the needle that is required to be maintained when we are inserting the needle here. Now, in case we do not maintain this angle from the long axis of the vertebral column, the needle tip is likely to hit some bone or the other, which bone we'll come to later on. Now, this is how it is. You can see there is a black line horizontal. This is vertical to the long axis of the spine. That is a red line you can see of the vertebral bodies. And there is another line, red line, which is parallel to the long axis of the spinous processes above and below. And it is this direction which is required to be maintained when the needle is being inserted. Okay, and that's the angle that we need to maintain when the needle is going in. So here, if we look at the earlier, what I showed was I can go back, this was the lumbar region. And what we are looking at now is the thoracic region. You can see that there's a dark black line in the horizontal plane, and it is intersecting the long axis of the vertebral column. And see how much angulated the spinous processes here are. Now, since the angulation of the spinous processes is quite large, it's nearly 45 to maybe 50 or sometimes even 60 degrees from the spine. So the needle direction should be in this manner, which is about 45 degrees from the perpendicular, and only in case your needle is in that direction, which is parallel, which is decided by the angulation of the spinous processes, that you will be able to get to the CSF. Otherwise, you will not get. Okay, so this is what I'm trying to compare. If you see the right upper corner, there is so much angulation of the spinous process to the long axis of the vertebral column, and in the lower on the right side of the two pictures on the right side, you can see that the angulation is much less as compared to the thoracic region. The thoracic spine is much more angulated as compared to the spinous process of the lumbar region. Now you can see the angle, this yellow, area that's there is telling you the angle of the needle that is required to be maintained there. Okay, now this is in a nutshell. How much angle should be there to the long axis of the vertebral column? In the lumbar region, it should be 5 to 15 degrees. Now, if you are in the lower lumbar region, the angulation should be just about 5 degrees to the vertical. And as you go up, say L1, the angulation should be at about 15 degrees from the vertical. And in the low thoracic region, it is about 15 to 30 degrees. In the mid thoracic region, where the angulation of the spinous process is the maximum, there you have to have 30 to 45 degrees or even 60 degrees angulation of the needle from the vertical. And as you move up, the angulation starts now decreasing. The mid thoracic region, as I told you, has the maximum angulation of the spinous process, it is the most difficult area, because to maintain the angulation of the needle parallel to the spinous process, long axis of the spinous process, sometimes it's difficult because it's basically a guesswork, your own experience and your expertise. Now, as you move up in the upper thoracic region, the angulation decreases. So the angulation of the needle now should be around 30 degrees. And in the cervical region, again, from 32, it goes on decreasing to 30 degrees. And in the upper, cervical region, say C3 and 4, the long axis of the spinous process, just about 15 to 20 degrees. Okay, now comes the direction of the needle. Now, you all would agree with me that what we have been taught by our seniors and what our books also say, the classic teaching is, if the patient is lying supine on the table, of course, the neck is flexed. Let's imagine, neck is not only neck is flexed, the hip is flexed, the knee joints are flexed, so that you can have the maximum curvature available to you posteriorly towards your side, where you're standing to give the spinal anesthesia. So in this position, when the patient is on the lateral side, the needle is set to be perpendicular. The patient, it should be parallel to the surface of the table when the patient is lying. You can see there are two lines which are drawn. One is a red line. This is saying it is parallel to the table, and there is one which is purple line, which is on the table. You can see on the white sheet that is there. So that is the surface of the table, and this red line is the line which is parallel to that purple line, which is denoting the surface of the table. Now this is as per the classical teaching, but it's not just the needle should be parallel to the horizontal surface of the table. It is with a condition that the patient back should also be perpendicular to the table. Now here in this case, since the patient is lying in this manner, let's see what is the angulation of the patient's back to the surface of the table. It is not exactly vertical. It is somewhat declining forward in the upper region. The lower is fine, it's okay, but you can't do anything about the lower, but the upper region has moved forward. It is not vertical to the surface of the table. Now, if it is not vertical, it is going to create problems for us, because the needle will not go where we intend it to go. Now, let's see that we have put in the needle right in the midline after feeling the spinous process. We determine the interspinous space, and there, after giving local anesthetic, whatever you do, and you push the needle inside, and where does the needle go? Now see this picture. The white line is the back perpendicularity, or the angulation, or the angle of the back in relation to the surface of the table. The needle, which is the red line, it is just depicting the needle, is not vertical to the white line that is connecting, that is the surface of the back of the patient as the patient is lying. So when you're inserting the needle at the midline, you can see that it is hitting a bony process, which is usually the lamina of the vertebra. The needle tip is going off the midline. The midline, what you have here is this one here. I don't know if you can see with the pointer, the yellow oval area, that's where the needle should go to obtain CSF. Whereas this needle you have inserted quite right at the midpoint of the interspinous interspinous space. But the needle is going away because the patient's back is not perpendicular to the surface of the table. So that's why the problem is occurring. Now, what are the options left? You had put the needle correctly. One condition is fulfilled, that you have inserted the needle in the midline. The second condition you did not fulfill because the patient's back is not perpendicular to the table. Now, what do? There are two options you have. One is that you turn the needle in a way that it is now perpendicular to the back, which actually is not perpendicular to the surface of the table. But what you have done is you have changed the direction of your needle so that the angle in the transverse plane is 90 degrees on either side. Now here, when you are pushing the needle in the midline, in the interspinous region, it's now going straight toward the CSF, where exactly it is shown there. There's this yellow oval area that's shown as the place where, which is the area of interest. That's where you want the needle tip to be there so that you can obtain the CSF. So this is one option, that you change the direction of the needle and not the direction of the patient. The second option that you have is you tilt the patient. You put the patient's back in the perpendicular plane, absolutely perpendicular to the surface of the table. Surface of the table is depicted by the purple line on the left side, you can see at the bottom. And the vertical line, you can see that is the line which is showing that the back is perpendicular to the surface of the table. So now you have gone in the midline and the needle would straight be going into the CSF. Now this is one aspect. The angulation of the needle to the longitudinal plane is not talked at this moment. We are only talking of the angulation of the needle in the transverse plane. That's it. We come to the other angle later on. Okay, this is the direction of the needle. Now you can see the white line, vertical white line is showing the back of the patient, which is by and large perpendicular. And the red should take you there to your target area. But in case you can see that the needle is not perpendicular, this needle will never go to CSF because it is going to hit the bone somewhere. And which part of the bone it hits, we'll come to later on. There is tremendous role of flexion and extension, and I'm sure you are very, very familiar. Whenever you're giving spinal, you try your best to make the spine flex as much as possible. You flex the hip, you flex the knee joint, you flex the cervical region also, and tell the patient ke, ko piche nikal ke rakhna. Ko piche nikal ke rakhna means that the patient gives you the maximum curvature for you so that you can get, or you can put your needle correctly inside. Now, these are the two pictures I have shown. One is that of extension, the other is of flexion. Now, what is the difference between the two? Looking at the picture on the left side, that is the extension. On the anterior side, you have the vertebral bodies. You can overlook those. Come to the left side. The left side of the picture, you have the two processes, spinous processes, which are projecting towards the left side. Now come to the same picture on the right side now. Now this is the position of the spinous processes in the flexion position. Now compare the gap between the two spinous processes at the time when the extension of the spine is there, of the vertebral column is there, and when the flexion of the spine is there. You can see that there is a big gap. There is an increase in the space between the spinous processes when the spine is in extension. So in flexion, you have opening up. That's another term which is very commonly used, opening of the spinous space, interspinous space, because the two spinous processes go apart and you have more space available for your needle to go in. This is the gap which I am referring to. You can see on the left hand side, this red line is actually depicting how much is the gap between the two spinous processes that you feel when the patient is in extension and in the flexion position. Okay, so that these two lines again show how much is the difference in the how much is the difference in the gap between the two spinous processes. Now, if we look at the spine from the back, from the posterior aspect, what we see here is on the lateral side, you have the transfer processes, just to orientate. And in the midline, you can see the oval structure, not oval, elongated structure that you see, which is marked as the spinous process. There is spinous process above, and there is another spinous process of the vertebra below. Then below the spinous process, what you can see, there is a projection of the bone, that is the inferior articular process of the vertebra above. And likewise, you have the superior articular process, which is coming from the vertebra below. And these two articular processes, they form a joint posteriorly, and this joint is known as the facet joint. Okay. Now, this is just to have a look at the different structures to understand what exactly, how exactly the spine is formed. But more than that, what's important to look at this picture here is a dark area which is seen in the middle. And now this dark area is, how is this dark area made? This dark area actually is the interlaminar hiatus. Now, why laminar? Because it is the lamina of the vertebrae posteriorly, which are the upper and the lower limit of this space. And on the lateral side, that what we have here is the medial aspect of the inferior articular process of the vertebra above, and the medial aspect of the superior articular process of the vertebra below on either side. So this interlaminar hiatus is formed say anatomically. Above is the lower border of the lamina of the vertebra above. Then the medial aspect of the inferior articular process of the upper vertebra. Lower down, you have the upper border of the lamina of the vertebra that is lying lower down, and the medial aspect of the superior articular process on either side. Now, this interlaminar hiatus is what is the important structure through which the needle has to go, because if your needle is not passing through this, your needle is hitting the bone somewhere. And the most likely sites where the bone is hit, it's around this interlaminar hiatus. It may be the lower aspect of the lamina of the upper vertebra, or the upper border of the lamina of the lower vertebra, or on the either side, whether it is superior articular process or inferior articular process or the facet joint. So these are the points where the bones are hit quite often, most often indeed. Now look at the vertebral column now. On the left side, you have the vertebral column where there is extension of the spine. The spine is not flexed. On the right side, you can see that there is flexion of the spine, which has opened up the spaces. You can see that the interlaminar hiatus has opened up more. What's important is not as much as opening of the interspinous region. Interspinous region you can feel with your thumb very well, and you can put the needle where, in the middle of the interspinous region. But what's more important is, because this interlaminar hiatus, which is at a depth of about 4 centimeter, maybe 3.5 centimeter or 4.5, which is the average length from the skin in adult healthy person. So this interlaminar hiatus is at about 3.5 to 4 centimeters from the skin. And it's difficult to precisely tell what are the boundaries of this, where exactly your needle might be hitting if it is hitting the bone. So more wider it is, easier it is for you to push the needle through this, because ultimately the needle after piercing this has to go to the CSF. Okay, now this is the transverse dimension of the interlaminar hiatus, whether the patient is in extension or it is in flexion, you can see that this is by and large the same. The width of the interlaminar hiatus is by and large the same, whether the spine is in extension position or it is in flexion position. Now let's see what has happened in the extension and flexion position. See on the left side, the space between the two spinous processes at the back on the left side is much less as compared to the space between the two spinous processes on the right side. It's nearly the double, and thus this is again what is very commonly called as the opening up of the spinous processes at the back when the patient has assumed the flexion position. Now leave that aside, because as I told you that you can put your finger very well, you can put your thumb very well and figure it out where exactly is the middle region of the interspinous space, interspinous region where you would like to put your needle in. But you can see the change in the size of the interlaminar hiatus when the flexion has taken place. You can see there is certainly opening up of the interlaminar hiatus when the spine with the flexion, in the flexion position as compared to that's there. Even this much of opening up of the interlaminar hiatus is good enough for you to make to get your needle in the CSF. Okay. Now the next point is midline or midpoint. When I say midline means that the midline, say you have, right from the cervical region right up to the sacral region, if you join the vertebral spinous process, so that gives you the midline of the vertebral column. Now midpoint, I am referring to the space between the two spinous processes. Now, should we go in the midpoint between the two spinous processes, or we should be exactly in the midline of the two spinous processes? Let's see how it is. Now, this is again the same picture magnified, and this is the red line is what I'm saying, the midline, exactly midline of the vertebral column, which is connecting the which is connecting the spinous process of all the vertebrae at the back. If we see the laterality, or you can see the gap space or the distance from the midline to the extreme width of the interlaminar hiatus, it is almost this much that you can see on both the sides. Now, when this is the widening of the interlaminar hiatus as the spinous processes have separated apart when the flexion has taken place. So here you can see if you have deviated from the midline, the possibility of your needle getting through the interlaminar hiatus is less than the possibility of the needle going through in case your needle is going off the target in the longitudinal plane. Okay. What I've marked here is the white arrow, which is the white arrow, two-headed arrow, white. It is just this much gap that you have between the midline and between the transverse line, which is representing the maximum transverse diameter of the interlaminar hiatus. So you have only this much space. But in case you have put your needle right in the midline, you have much more margin of success to push the needle through this space through the interlaminar hiatus to the CSL to be successful in your spine. So this, now the bigger arrow that we have, two-headed arrow that we have, this is the margin of not safety, the margin of success. The margin of success has certainly increased now as compared to the margin of success with the in the transverse plane. All right. So the bottom line here is the ideal thing is midpoint on the midline. The needle should be precisely in the midline, and it should be on the midpoint of the two spinous processes. But in case there is a mistake that is made, midline, maintaining the midline is more important than the midpoint, because in case you are off the midline, your margin of success is less as compared to in case you are little off the midpoint on the midline. Still the needle can get through the interlaminar hiatus to the CSF that you want to get to. So midpoint on the midline is ideal. And in case there is some error, the midline still is more important than the midpoint of the two spinous processes at the back. Okay, you all know what are the ligaments to the way to the space, ligament to the subarachnoid space. So you are very, very familiar. I don't think I need to go much into it. This is supraspinous ligament, which is connecting the tips of the spinous processes at the back. Then there is interspinous ligament, which is connecting the upper and lower borders of the spinous process. And then you have the ligament of flavum, which is attached to the lamina of the vertebra above and the lamina of the vertebra below. And these three ligaments are the ligaments which the needle has to go through, needle has to pass through before it goes to the CSF. If you are performing the spinal anesthesia in the midline, the midline. It's not paramedian. Paramedian, you bypass the supraspinous and the interspinous ligament, and the only ligament that comes on your way is the ligamentum flavum in the paramedian position. In the midline, you have all the three ligaments which the needle goes through before it gets to the subarachnoid space. Now, you also know which ligaments calcify. The supraspinous ligament does calcify, right? And the interspinous ligament also calcifies, but the ligamentum flavum does not calcify. It's a very important fact again, and I think it's a very important question from the point of view of the examiners also, and the students must know that of the three ligaments that we have on way to the CSF for the needle to cross, the two of these calcify, that is the supraspinous ligament and the interspinous, and the ligament flavum does not calcify. And it is this very fact that we assume the paramedian position in a patient who is old with the ligaments are calcified. You don't feel the interspinous space well only because the ligament is calcified. You don't have the bony prominence like you have at the tips of the spinous process. You have almost similar. There may be small depression, all right. You can make out that probably this is a region which is not the region of the spines, the tip of the spine, but still even that is calcified. So you assume the paramedian position because you can bypass these two ligaments, supraspinous and interspinous, and after piercing the skin, subcutaneous tissue, you go through the muscles, and from the muscles, you go straight to the ligament of flavum, you pierce the ligament of flavum, which doesn't calcify, and then you go into CSF, and your spinal is successful. You are happy with the outcome of this. And this, as I said, ligament of flavum, since it doesn't calcify, is the basis of paramedian approach. And why this ligament does not calcify, the ligament of flavum doesn't calcify, is that it is composed of yellow elastic fibers, whereas the other ligaments are not having yellow elastic fibers. So wherever the yellow elastic fibers are there, whichever ligaments are there, those ligaments do not calcify. Now looking at the attachment of these of the ligament of flavum, this is attached superiorly to the anterior-inferior border of the lamina. Now that's it looks a little more complex. Anterior-inferior border of the lamina. It's not only the inferior border of the lamina of the upper vertebra, it is the anterior aspect also. So both the things are important here. Anterior-inferior border of the lamina. And if we go low down, where is it attached? It is to the posterior superior border of the lamina. Again, there is another term which has come. Earlier we were thinking that, earlier we were saying that it is only the superior border of the lamina. But to be more precise, it is not just the superior border, it is the posterior superior border of the lamina as well. So this has clinical relevance. And what is that relevance? We'll see in this in the next few slides. Well, epidural space is a space you know very well that is surrounded by the spinal meninges. It's a actual space, and ligament of flavum binds epidural uh, uh, space posteriorly. It's more wide at the L2 region, that's about 5 to 6 centimeters, and it's narrowest at the level C5, where it is narrowest the 1 to 1.5 millimeters. Now, this is what we have already said. Superiorly, it is attached to the anterior inferior border of lamina, and inferiorly to the posterior superior border. Now, this you can see here. What I mean, this is the ligament that you can see here. You know, in the where my cursor is moving. This is the ligament of flavum, and this small triangle that I made is what is the posterior superior aspect of the lamina of the vertebra below, and this is the anterior inferior aspect of the lamina of the vertebra above. Now let's see what happens to the needle as it goes further. Now, if the needle is straight in the midpoint and of course the midline, the needle is going through because there is enough space. You are absolutely parallel to the long axis of the spinous process, and the needle is going piercing through the ligament of flavum into the CSF. But in case you are not exactly in the midpoint, you are on the midline, but you are not exactly in the midpoint. You can see that now take this red line as a needle. The other needle I couldn't do anything because that is how the picture was. Take this red as a needle, that you are inserted. Now you have gone very well through the supraspinous region. It has pierced that. You have gone through the interspinous region. Also, you have hit the ligament of flavum. You did feel that the needle has entered the ligament flavum. You could make it out from the resistance that the needle movement is encountering. And after feeling the resistance, you hit a bone. Now this shows that the ligament of flavum was entered. However, it is then meeting the bone. Now what has happened? The needle has struck the posterior superior aspect of the lamina of the lower vertebra. Now what to do here? Now you change the direction of the needle. You withdraw the needle and redirect it by increasing the angle in the capsular direction. So this red line would need to be, let me go back. Yes, this red line, which is depicting the needle will have to be pulled out, and it will be angulated little more towards the capsular region, and that's how it will be going into the ligament of flavum, and of course it will be passing the ligament of flavum into the CSF. You can see this is the earlier position was the dotted line. You withdrew the needle and you directed it more capsular, and now you have bypassed this hit point which was earlier there, and now you are passing through the ligament of flavum and into the CSF. So that's how you correct your needle which has hit the bone, so that you can get to your target without making another puncture point on the patient's back. All right. Now, there were two situations there. Needle hits the bone before entering the ligament flavum. One is, this is the position of the needle where it has hit the bone without ever having gone in the ligament of flavum. Because from the feel of the needle advancement, the needle as it moves forward, you can make out whether it has entered the ligament of flavum or not. However, if it has entered the ligament of flavum and then hit the bone, I told you that increase angulation towards the capsular region a little more, and you will get in. Now the second situation is, you have put the needle in and you have hit without hitting the ligament of flavum. You have crossed the supraspinous ligament, you have even gone the interspinous ligament, but then you did not encounter the ligament of flavum and you have hit the needle, you have hit the bone. Now this means that you have hit the under surface of the spinous process of the upper vertebra. Now what do? For this to go, before the needle has pierced the ligament, now you withdraw the needle and redirect it after decreasing the capsular angle. The issue here is that your angulation is more than the long axis. It is not parallel to the long axis of the spinous process. It is more than that. If it is more than that, only then will it hit the undersurface of the spinous process of the upper vertebra. So this is what it should be now. This this dotted line which was the original position of the needle when it has hit the bone without hitting the ligament, and now you have withdrawn and decreased the angle which was more in the capsular direction, and now you will see that this solid line is going from the same point of puncture on the skin, and it is now going through the ligament of flavum into the CSF, of course, and you are happy with your performance. So that's how you change the direction. The next is now the angulation of the spinous process once more. Why is it important to know the angulation of the spinous process with the long axis of the vertebral column? It's again important. It's important to note so that you can maximize the possibility of getting through the interlaminar hiatus, which is a crucial point. It's a small space between, as I told you earlier, which is bounded by the different bones, and this will minimize the bony hit that you will get. Now, bony hit, which bone is hit? The bones that are hit, I told you earlier also, this can be superior articular process of the lower vertebra, or it can be inferior articular process of the upper vertebra. It can be right lateral if the patient is in the left lateral position, or it can be left lateral if the patient is in the right lateral position. You may be hitting the facet joint if you are hitting at the site where the superior and inferior articular process are forming a joint, facet joint, or you may also be hitting the lamina of the vertebra above, or you may be hitting the lamina of the vertebra below. So these are the various sites which are shown here. These are the two laminae and the facet joints in the transverse plane, and in the lower region you have the superior border of the lamina of the bone over the lamina of the lower vertebra. Okay, now the direction of the needle once again. Let's see take this red line as the actual needle that you have in your hand. The black lines are depicting the long axis of the spinous process above and below. You can see that the gap between two black lines is the gap through which, if the needle is passing, will go through the ligament of flavum. Even if it is at a lower level where it is shown, as long as the needle stays within these two black lines, it will get through the ligament of flavum and into the CSF. Now let's see that needle is not there. This is maximum because the needle is absolutely perpendicular, not perpendicular, it is absolutely parallel to the two lines which are shown here, the two dark lines which are shown here. Now let's see that the needle is not parallel to these two lines. What happens there? Now here again, the black lines are as they were earlier. The direction of the needle has now been changed. Now the margin of success is restricted. Earlier it was the gap between the two black lines. Now the gap has reduced. That is the gap between the two white lines, dotted white lines that you can, the interrupted white lines that you can see. Now if your needle is in this region, between these two lines, you will succeed, but the success rate or the possibility or the margin of success has decreased now. Earlier it was between the two black lines, which was a wider region. Now it has decreased because the angulation of the needle is not parallel to the long axis of the spinous processes. Now let's see what happens in case it is further more off the target, or it is not parallel to the long axis of the spinous process or the black lines that you see. Now the margin of success has decreased further because these dotted lines have come a little more close. Now whether the needle is inserted at this point or it is at the little lower level, as long as it stays in this channel, the needle will get through. Otherwise it will hit the bone, some bone or the other. Now as we are increasing the angle, increasing the angle toward the sacral region, I'm saying. So as we are increasing the angle, or we are decreasing the angle, the capsular angulation of the needle, the margin of success is decreasing further. You can see that now the margin of success is much more restricted as compared to initially what we started with was the black lines. So now the margin of success has decreased. It is defined by these two interrupted white lines that you can see there. Now we have still gone further. The angulation is still more. Now the margin of error margin of success is very, very limited. Precisely in case you stay in this line, only then you will be able to go to CSF. Otherwise, you will be hitting some bone somewhere or the other on way to the spinal anesthesia. Okay. Now here in this, you have further increased. Now there is no way that the needle can go through the ligament of flavum into the CSF, because you are grossly wrong. The direction of the needle is grossly wrong. What I mean by grossly wrong, it is not parallel to the long axis of the spinous process of the vertebra that we have. Okay, I'll take another 5-10 minutes or so. I hope I can be allowed that time. Okay, the force required at different levels. The maximum force required for the needle to be pushed is ligament of flavum. Because why more? Because it is the thickest ligament, in the midline over there. Then the next is the supraspinous ligament. This is the width-wise. This is less than what you have in the ligament of flavum. The ligament of flavum is widest in the midline, and as you go laterally, it goes on. The width goes on decreasing. Interspinous ligament. Here the force required is minimum, because it is you may not be precisely in the interspinous ligament if you're deviating somewhat from the midline, but the resistance to the advancement of the needle as it goes through the interspinous ligament is much less than what you have with the ligament of flavum. So it is these three resistances. If you can feel with your feel in your hand when you are pushing the needle in, I think you can make out where exactly your needle is at any given point of time. Okay, friends, coming to the take-home points. One is the back should be in the flex position, that you all know and you all perform regularly in your practice. So why we need the back to be in the flex position? It's very, I've explained it in different diagrams. This is what I mean by the flex back in case a patient is lying supine, lying in the lateral position. The hip should be flexed, the knee should be flexed, the neck should be flexed, and the patient should have his or her back as much convex posteriorly as possible, so that you can feel the interspinous ligament clearly. That's one. And then the second thing is that you can have the ligament, the transverse process, the spinous process opened up as much as possible. And if the patient is sitting down, on the table, here again, the hips as far as possible should be somewhat flexed. The knees, of course, should be flexed, and the cervical region, the patient's head should be, looking downwards, so that you can have as much curvature of the back towards you as possible. That's the take-home point one. Take-home point two. It should be 90-degree angle on either side of the needle in the transverse plane. See, here I'm saying in the transverse plane, not the longitudinal plane. Longitudinal plane is from head towards caudal region. It is the transverse. It is at 90 degrees, to that plane. It is in the transverse plane. Why it is so? Here you can see if the red line is depicting the needle, patient's back is absolutely perpendicular to the table. So if the angle on either side of the needle in the transverse plane is 90 degrees, the chances of your success are very high that you will go straight into the CSF on the first hit. That is take home point two. In case you are, in case the patient's back is not perpendicular, there are two options that you have. One is you change the direction of the needle, that it now comes perpendicular. It is perpendicular to the patient's back. Or the second option is that you change the position of the patient so that the patient's back is now perpendicular to the table. So either way you can do it. The third is there should be 90-degree plus cephalic addition to this angle in the longitudinal plane. Now, why it is, how much it should be there? As I told you earlier, the angulation plus the addition to the perpendicularity of the needle here in the lumbar regions 5 to 15 degrees, the lower lumbar region say L4, L3 or L4, L5, the angulation is of the spinous process just about 5 degrees. As you go up, it goes on increasing. In the upper lumbar region, it is about 15 degrees, and the lower thoracic region, it is 15 degrees because the angulation of the spinous process goes on increasing from lumbar region as you go to the thoracic region. In the mid-thoracic region, the angulation of spinous process is maximum, that is about 45 degrees or even more. In the upper thoracic region, the angulation goes on decreasing. It is just as much as the angulation in the lower thoracic region. So it's, you need to angulate your needle to the perpendicular to the back to about 30 degrees in the cephalic direction. And in the cervical region, it is anything from 15 to 30 degrees, depending on which level of the cervical region you are going in at. Then the next take-home point is that the midline is more important than the midpoint. Ideal, as I said, ideal is midpoint on the midline. But of the two, midline is more important than the midpoint, because if your needle, even if it is not exactly in the midpoint of the two spinous processes, but it is in the midline, the success possibility is more than the success possibility in case it is off the midline, even if it is in the mid towards the midpoint. But if it is off the midline, then you are likely to hit the bone more often. The next, this is the reason, because what you see, the smaller bi-headed arrow in the transverse plane is the margin of success that you have here, and the wider angle or the bigger bi-headed arrow is the margin of your success if you are away from the midpoint on the midline. And the next point is change in the resistance to the needle advancement, needle movement. You must appreciate, and I'm sure having given even a few spinals, you can make out, okay, now the needle has gone through supraspinous ligament, the less resistance now you are meeting, you are in the interspinous ligament, the needle has suddenly increased, resistance that is met to its advancement, now you are in the ligament of flavum, and then suddenly, you lose the resistance, you enter the epidural space, there's hardly any resistance, the dura puncture, not much resistance is required sometimes. As your needle, as you give more spinals, your fingers can even sense as a bit of a pop as it is felt when the needle is piercing through the duramater. So that's the change of resistance. Try to learn, try to experience, try to realize the change in resistance. That will help you to know where exactly your needle tip is going. Well, friends, thank you so much for giving me this time I've explained. I'll be too happy to answer any questions that you have. I request the moderators to kindly take over, and if there are any questions, please let me know so that I can answer those. Thank you so much once again. I thank again the ISA National to give me the opportunity to share time with you and speak from my experience with you. Thank you. God bless you all.
Thank you so much, sir, for this wonderful presentation. It's been an absolute honor to listen to you, especially those images and wonderfully illustrating your talk with the help of those images. It shows the amount of hard work you have put in your webinar. So I'm sure all the postgraduate trainees and all the delegates must have benefited through your talk. Sir, with your permission, I would like to take a few queries. Can I, sir?
Please do, sir. Please do.
Yeah, sir, first query is from Dr. Anil Kumar. He would like to know what are the tips in doing spinal anesthesia for patients with ankylosis of lumbar spine?
Well, ankylosis or lumbar spine, as I told earlier, the ankylosis basically there's fusion of the not fusion, there's calcification of the ligaments. What you see here is you don't have any space opened up between the two spinous processes, and the option left for you is to go in the paramedian plane. And paramedian plane, why you are successful in the paramedian plane is that you bypass the two ligaments that calcify. Supraspinous ligament as well as the interspinous ligament, they do calcify. And when you are in the paramedian position, you avoid these two ligaments. The only structure that you PS1, of course, is skin, the subcutaneous tissue, of course, and then you straightway hit the ligament of labrum, which doesn't calcify. The needle goes in and you are successful. So this is the approach you should have for any patient, whether it's ankylosing spondylitis or it is calcified ligaments. The patient is too old, where the ligaments are more likely to be calcified. So this will help you out to get the spinal anesthesia in such patients.
Thank you so much, sir, for addressing to the query. A similar type of question: what would be the method if the patient is of scoliosis?
Scoliosis. Now that this is a different proposition. This is a difficult proposition. Now, difficult, I'm saying there are two aspects to it. One, of course, in scoliosis, there is kyphoscoliosis. There is change in curvature of the spine. It is either more convex or it is somewhat concave. Apart from that, what's more important is there is rotation of the spine. The spinous process is not exactly vertical to the back. Okay. Now the spinous process also is moved away because there is rotation of the spine vertebral column in the region where there is kyphoscoliosis. Here, now if you follow the same rule of keeping your needle parallel to the surface of the table, you may hit the bone again because the vertebral spine has rotated. It's not only the curvature has increased, it has also rotated. So in this situation, now if you have scoliosis toward the left side, you should increase the angle of the needle towards the left side more than normal, because only then you will be maintaining the center of the longitudinal plane, and your needle can go through the interspinous ligament. If the curvature of the spine or the scoliosis of the spine is on the right side, you have to do it on the other direction. So it's not that you will maintain the needle direction parallel to, apart from the change, the angle that you maintain for that particular region, say it's the lumbar region, say upper lumbar region, apart from about 10 to 15 degrees tilt that you give to the needle in the cephalic direction, here you have to change the direction of the needle towards the transverse plane also, towards the side of the spine, or toward the side of the scoliosis that is occurring, because only then you will go there. It is a rotation of the spine which makes spinal difficult in these cases.
Thank you so much, sir. Again, another query: in extreme obese individuals, it is difficult to palpate the midline. How to overcome this situation, sir?
Oh, yeah, that's a very important question. Whoever has asked, my compliments to that.
Dr. Anil Kumar, sir.
Yeah, Dr. Anil, the very well thought of question. Now it's a very difficult thing. There are certain things which can be done. One, of course, the patient is say lying down position or sitting position, that's immaterial. You start putting a small prick to the patient on the, say, from one side, left side. Keep on going towards the midline. Keep on going towards the midline. And as you are exactly in the midline, and when you are crossing the midline, patient will say, now the needle is more on the right side. Patient will also direct you to that. आपने एक left side पे, away from the midline, 2-3 centimeters, 4 centimeters, you give a small prick to the patient. Ask which side your needle is. दाएं side है या बाएं side है. Patient will answer, ये तो left side पे. Now come little more medial, say about 1 centimeter. Now अभी भी left में है but कम है. अब वो कहेगा हाँ अब तो ये बिल्कुल सेंटर में है जी. Then you go on another half to 1 centimeter. Now you say now up to right side पे आ गई. So that will be one help. But it may not be successful in all the patients because patients may not sometimes give you a very clear position. Here is the catch. Now, if the patient is sitting in the sitting position, there is a groove which is exactly in the midline. In obese patient, that groove will be there, which will be because of the fat deposition. The fat deposition is minimum in the precise in the midline over the supraspinous ligament. It is more towards the lateral side. So that groove itself will guide you to the midline. That's one thing. But it tells you that that's where the midline is. Now the next question, which this gentleman who had asked question, he might be thinking, कि सर वो midline तो चलो आपने बता दी, अब needle कहाँ पे डालनी है वो नहीं समझ आ रही, spinous process feel नहीं हो रहे. Now, like here again, well, of course, the ultrasound people who are very, very well adept at it, they can very easily make out, okay, there is a spinous process, and here is that needle should not be going, it should be going between the two spinous processes. But in case you do not have the ultrasound machine, what you can do is, you can, of course, you must palpate as far as possible, and by and large, with experience, you can make out that this probably is the space between the two spinous, interspinous region. This is a space where your needle should go. However, let's say that you felt that this is the place which I think it is in the midline, but this is the interspinous region, and you put the needle in, and you hit the bone. Now, if the needle has hit the bone, say about 1 or 2 centimeters, you know that's a obese patient, and the needle will travel about 6, 7, 8 centimeters before you get the CSF. If it is hitting the bone at about 2 centimeters, it obviously is hitting the tip of the spinous process, and it hasn't gone beyond. So if the needle has hit there, now you are sure that this is one spinous process. Now the next needle that you are going to put in is say about half 1 centimeter below. And now you will see that if you are in the midline and now you are going about 1 centimeter below the previous needle, it will go through the supraspinous ligaments very comfortably. And if you maintain the angles correctly, parallel as much possible, parallel to the long axis of the spinous process, you will be, getting to the spinous process. One more thing is, it is best to give spinal anesthesia to a obese patient in the sitting position. Now, why sitting position? Now, let's say that this patient is lying in the lateral position, obese patient, or super obese patient is lying in the lateral position. Now, I was telling you about the groove, which is in the midline, that is formed by the fat on either side of the midline. The minimum fat deposition is in the midline, because of the ligament that you have over there. Okay, now this groove, which is earlier depicting the midline when the patient is lying down, now it sags down because of the lot of fat. The whole groove has fallen down. It is not exactly in the midline. It is at a level lower than the midline. Now, if the patient is in a lying down position, do not trust this groove. The midline is somewhat higher. So if you keep going in this midline again and again, thinking that yes, अरे मेरी direction की needle तो ठीक है, पहले उन्होंने कहा ये 10 डिग्री यहाँ पे होना चाहिए, बुक किताब में लिखा है और मेरे सीनियर भी कहते हैं यहाँ 10 डिग्री होना चाहिए, और मैं 10 डिग्री का maintain भी कर लिया, but I'm hitting the bone again and again. It is because you are not in the midline. You are following the groove. Groove is not to be followed when the patient is obese and is in the lateral position. Groove has to be followed. The midline, for the determination of midline, in case the patient is sitting, it's not that in the sitting position the fat doesn't sag this midline. It sags, but the midline remains midline. It doesn't change the position of the fat on either side. Midline is still maintained, despite the fact that the fat has lowered the whole thing, but the midline is still maintained. So for an obese patient, try to give it in the sitting position, and do not follow the groove as a guide for you to determine the midline of the patient. I hope I've made it a little clear.
Absolutely, sir. You have made it very clear and very lucid also. And Dr. Anil Kumar has also written that we also ask our patients to guide us towards the midline. At times, they also palpate their midline, and we mark them pre-procedure. Exactly. And you also touched about the availability of imaging modalities. Yep. In some institutes, USG and fluoroscope are available. And as you have rightly said that if available, these imaging modalities can be used.
Yes.
Ankur, there are more questions, please.
Yeah, sir, one question is from Dr. Matthew. Can
Yeah.
you kindly suggest the references which you have taken from your literature?
Well, I'm sitting at Chennai at the moment, but kindly forward the email address, or else I can send it to Dr. Naveen and he can further send these references to, I surely will provide. I'll send it to Dr. Naveen. Dr. Naveen can send directly to that person, or else you can send the email to me and I can send it a copy to Dr. Naveen and of course to the gentleman who has asked that question. Sorry, I don't have the references ready at hand because I'm not in my workplace. I'm a little away from that.
Thank you so much, sir. One question is from Dr. Santosh Agrawal.
Yeah.
Which should be the point of needle entry? Should it be upper border of lower spine or lower border of upper spine? Which one is preferred?
Okay, right. A very important question again, and it's a very practical question. I'm sure this person, Dr. Santosh, the madam would have given a lot of spinals before she realized कि भी मैं कहाँ पे दूँ ऊपर lower border of the upper spine or the upper border of the lower spine, right? Very important point here again. My point here is the best site for the skin puncture to give epidural is midpoint on the midline. Midpoint on the midline. However, if you don't want to be in the midline, the best is the upper border of the lower spinous process, then rather than the lower border of the upper spinous process. Now, why? The reason to that is if you are at the upper border of the lower spinous process, the general trend is that we angulate the needle a little more than what actually is required. We often go at L3-4 place or L3 interspace or L2 interspace. Here, the angulation that we do to the needle is usually more than what is required. So, in case you are going at the upper border of the lower spinous process, even if the angulation is more, still the needle can pass through the interlaminar hiatus to the CSF. But in case it is it's on the other position, that is the lower aspect of the upper spinous process, if the angulation is little more, you are going to hit the undersurface of the spinous process there, and the same situation that you felt the supraspinous is passed, interspinous is passed, you don't feel the ligament of flavor, and you have hit the bone. So that's likely to happen. That's my personal experience, that it should be at the upper border of the lower spinous process.
Thank you so much, sir. And there has been emphasis and re-emphasis on the same concept which you have been highlighting, midpoint of the midline. And if not, then upper border of the lower vertebra.
Precisely.
Sir, another question is from Dr. Mohan Pathak. Yeah. How to manage in severe kyphoscoliosis already operated without implant in situ and without the availability of ultrasound?
Severe kyphoscoliosis operated.
Yes,
I
sir.
would suggest that stay away from this patient with regard to regional anesthesia. Because in case the patient has had laminectomy or any repair on the spine there, you are possibly missing out on the bony landmark. There may be laminectomy which has already been done. You may not feel the ligaments properly. So in such cases, I would not suggest that the patient should be given spinal anesthesia. However, if the region where you like to put the needle is not operated upon, the operation is higher up or low down, wherever it is, if that region is clean where you think that the spinal can be given, you can still there, but I'm not too sure about the medical legal aspects of it. The best thing is to stay away from such regions because of medical reasons medical legal reasons also, and apart from the fact that you will not be able to feel the bony resistances very well. But in case you are doing it with a proper consent of the patient, informed consent, patient doesn't, the general anesthesia is more risky to the patient, proper consent has been taken. So if the site where you want to give spinal is not operated upon, you can still do, and the rules remain the same. If it is severe scoliosis, if the scoliosis is more toward the left side, you got to angulate the needle in the transverse plane to the left side. Also, not only the angulation toward the cephalic side, so you have to have slight deviation of the needle toward the left side. If the scoliosis is more to the right side, then of course you have to direct the needle slightly to the right, apart from the caudal direction also. So that's my take on it.
Thank you so much, sir, again for addressing to the query.
Now we can.
There are no.
I think all the questions have been covered. Ankur?
Yes, sir. Yes, sir. All questions covered.
We can unmute all, and now the opportunity will be to all the participants to unmute themselves, and you can directly interact with sir. And I'll request sir also to unmute. And we, Dr. Baljit Singh sir, it's you will feel honored like me. Our teacher, Dr. Balbir Chavda, is also attending this particular lecture.
It's my honor to my teacher also. He is guru of guruon ka guru hai wo, to you know I can't think of a better person as a guide, or who has given so much guidance, love, affection, and not only just love and affection as a human being, as a teacher, a wonderful person, and I think I owe a lot to him. Wherever I've reached, I think he has a big contribution to my career advancement. So I'm blessed to have a teacher like him.
Dr. Chavda sir, please, few comments from your side, sir.
Thank you very much. I'm very much pleased to listen to the Dr. Baljit. He's very much, he's very proud that he's your best teacher. Again, I am very happy to see Dr. Naveen, again a best teacher, and he's doing very well. I'm already proud of these boys, and I feel myself lucky to have these to my students also. Thank you very much. I'm greatly honored to listen to your voice. It's an excellent topic. I think it's a extremely excellent, given all the aspects of it. Spinal is the one thing one should try and one should not fail it. And the only thing that we should know the anatomy properly, and so that we can use this spinal as the best method of anesthesia. Thank you very much.
Thank you, sir. Our honor and privilege to be your teacher, sir. We are blessed to be there, sir. Thank you so much for your blessings, sir.
Thank you, Dr. Baljit. What I feel many times for the spinal, what is more required is the patient cooperation than our expertise. If patient cooperates very well, it will be a very successful spinal. I used to demonstrate my juniors, closing my eyes, looking up or down, like I used to say that Matsya Yantra Veda Vidya, that is that how that Arjuna was shooting, seeing that this thing, you have to do like that. You have to, your idea should be only I should get the spinal exact point. You need not see that. See somewhere and give, and you will always succeed, and you will succeed if the patient is cooperating. Yeah. Uncooperative patient, yes, it is difficult. Whatever expertise, they will move that. But I always tell my juniors, see, don't take a, once you prick the skin, don't take the needle. If direction change, you will always get the spinal. It is only the direction we may need, either up or down. But many people, they prick many times, remove and prick, remove and prick. It is not required to remove. Just you have to change the direction wherever you go there. In the angulation, you have to change. That's what is required. That's thing. And it's such a beautiful lecture. You have demonstrated all the pictures, and also people will know that not that PGs, every anesthetist should see this lecture and study that how that angulation is more important. When you deposit in different angles, how it changes. Really, it is eye opener for everyone. People who pricked many times, remove the needle or do this. There is no need to remove the needle. And by the way, I have another case next week. Yesterday, one man came for a PSC. His spine was fixed. I don't know how it was fixed and what they have done. He told that my spine is fixed and an operation was done. So I don't know. I asked him to bring his X-ray, and all 4 years back his spine was fixed. He showed me the scar, but not the X-ray. So I'll have to use something. I don't know whether I will be able to give or not. What they have done that. Anyway, that is also more important. Thank you so much for that wonderful lecture. And everyone should see this lecture, whoever is doing spinal.
Thank you so much, Mr. President, for your kind words. I think what you have touched upon, I did not at all for a different reason, because until the patient is cooperative, he will keep on moving and make your job difficult. See, one aspect of the patient cooperation that we all do and everybody does is talk to the patient. Okay, bhai, आराम से लेट जाओ, थोड़ी सी हल्की सी needle डालने की and if you talk to the patient, that helps quite a lot. The other aspect that helps you to make the patient cooperative is to decrease the pain. Now, it's quite often seen that the local anesthetic is given, the needle is pulled out, and at the next moment, the needle is put at a side at place other than where the needle, where the local anesthetic has been given. There are two issues to it. One, you have not given time to the local anesthetic to act. We often blame, "Arey, local anesthetic ghatiya, ye hai, wo hai." Arey, it's not the local anesthetic ghatiya. Kindly give time to the local anesthetic to act. That's one. Secondly, you have given local anesthetic at a site other than where you are finally inserting the needle at. Then again, the local anesthetic is absolutely ineffective. What in my normal practice, I do is I give local anesthetic and let the needle be there. And once, and then I wait for about 1 to 2 minutes. And after 1 or 2 minutes, I'll pull that needle with which I have given local anesthetic, that hypodermic needle. And then at the same site of needle puncture, I put my needle in, spinal needle in, and I go forward. This way, the pain to the patient is minimum and the patient is very, very cooperative. And also, he doesn't have bad memory of the painful spinal, because you know very well. Most of the patients, they say, हाँ मैंने बच्चों का ऑपरेशन कराया था and जो needle है जो लगाई थी उसका दर्द बड़ी हुई थी, मेरे आज तक दर्द होती है. So this is often because we give local anesthetic at a site other than where we enter with the spinal needle. So I think these are few tricks with passage of time everybody learns, and everyone has his own technique of making things good for the patient and having the cooperation of the patient so that it can be easily given. A very important point, Dr. Venkatgiri, that you have touched. Thank you so much. I missed it out.
Thank you, sir, for the nice deliberations. Any other comments or somebody would like to interact with sir?
There is one more query from Dr. Mohan Pathak.
Please.
Sir, also for myelogram in severely dwarfed patient for CSF leak cases, how do we go ahead?
Myelogram.
Myelogram, yes, sir. How do we go ahead in conducting myelograms?
For conducting myelogram, okay.
Yeah.
See, the rules remain, the basic rules remain the same. This patient is, you said dwarf.
Yes,
Dwarf.
a dwarf patient coming for myelogram.
Yes. Now, the issue with the dwarf patient is that the interlaminar hiatus space would be much less than you would expect in a normal patient. There's a patient who is 6 feet tall and he's right in front of you. You have enough of this interlaminar hiatus and you can very easily go. Here, what all is required is absolute precision to the technique, and only then you can do it, because unless the needle goes through the interlaminar hiatus, you can't obtain CSF. So you have to be very, very precise with regard to this. Determine the site of needle penetration well, and have your needle as much parallel to the possibility of the longitudinal plane of the spinous process as possible. I think you can get through with that. That's the only thing that you can do.
Thank you so much, sir, again for addressing to the query. There is one more query from Dr. Ilyas. Should opioid like fentanyl in a low dose like 25 microgram, is it necessary to be given before conducting spinal anesthesia?
I don't think, at least I don't give it. I have never given it. And I don't know if it can be recommended. I would suggest that give a good local anesthetic to the patient, give a good chat to the patient before giving spinal anesthesia. I think it would work better than the fentanyl or morphine.
Okay, thank you so much, sir. Sir, one more query from Dr. Jesse.
Yep.
Recently, Dr. Jesse was being called to give spinal anesthesia for a procedure, stem cell therapy. However, Dr. Jesse felt clueless. Can you please guide us in all these situations?
Stem cell therapy.
Stem cell therapy.
In subarachnoid space.
In the subarachnoid space. Well, I have no experience with regard to this, so I would not like to comment on it. And I'll go through the literature and will search the literature and get back to that person. I'll pass it on to Dr. Naveen, and I think Dr. Naveen can communicate whatever my response to that is. Yeah.
Thank you so
Sir,
much.
I'm Dr. Anil here. I've got.
Yeah, please go ahead.
Dr. Anil, please go ahead.
Dr. Anil, please go ahead.
I think there has been some disconnection.
Hello.
Yeah, please go ahead.
Yeah, I'm Dr. Anil here, sir. Thank you for that wonderful lecture, sir. I have a small comment with experience when postgraduates, when they do give a local for spinal block, what will happen is they would have achieved a very good optimal position and they give local. And while waiting for that 1 or 2 minutes, the patient relaxes. So what will exactly happen is the relation between the skin and the point where you have identified it as a midline and midpoint, that relation with the internal structure varies. Say ultimately they end up with a bony prick or something like that. So it is very important to maintain that posture at least for 2-3 minutes till we insert a spinal needle. That is what my observation with the novice when they start doing the spinal anesthesia. Thank you, sir.
Point well taken, Dr. Anil. I agree the patient can move, and that can bring in a difference between the level between the skin and the deeper tissues move a bit. But if you maintain the point of puncture the same as it was before, even if the patient has moved a bit, I don't mean that patient should move, but even if the patient has moved, the pain to the patient would be less, because the most painful area that you have here is the skin. Ligament, as the needle passes through the ligament, the pain may not be as much. It's the skin area which is most painful. So if you are giving local anesthetic and you have inserted the needle at the same region where the local anesthetic was given, the possibility is that patient will you will succeed in giving spinal anesthesia. But your point is well taken that if the patient moves, there can be some difference in the structure of one where the initial local anesthetic has been given and the structures low down or deeper down.
Thank you, sir.
Thank you, Dr. Anil, sir, for sharing your experience, and thank you, sir, for addressing to all the queries.
I think Dr. Chitoda wants to make a point. Dr. Chitoda, sir, please.
No, sir. I just have a query. How many multiple punctures can we do?
I would say that there should be no multiple punctures. In case you decide your target once, spend more time and hit it, and once for all, it should be over. Maximum, there is no literature to my best knowledge that you can have 5 punctures or 10 or 15 or 20. I would say that you select the site well, spend more time, and then right in the first go, get in.
Okay, sir. Thank you.
Thank you so much, sir, again.
One more question, sir.
Yeah, please.
If the CSF pressure is less, sometimes I have encountered the CSF volume was less, but still we were in the CSF space. Any comments on that, sir?
Well, CSF volume less, I think normally it doesn't happen that CSF volume is less, and what you are trying to say is that maybe the CSF flow would be less. The flow of the CSF would be less because of 2 reasons. One is the fine bore of the needle, as you have say 26, 27, 28 gauge needle. Since the lumen of the needle is too narrow, the CSF is going to take time. You have got nothing but to wait and expect that if you have gone in with feeling that all the resistances and you feel that it is there in the CSF in the subarachnoid space, the CSF will come out, but you have to wait for one time. The second aspect is coring of the needle. Now, coring is that as you are pushing the needle in, there can be somewhat of tissue which can come between the tip of the needle and the tip of the stellate which is there. Now, if there is a small gap between the stellate and the needle bevel, so if that tissue is stuck there at the tip of the needle, that is going to further decrease the flow of CSF because it is not allowing the CSF to come through because it has blocked the needle partially. So these are the two main reasons why the CSF should, why the CSF comes slower than what you expect the CSF to be. Otherwise,
thank you.
yeah, if the CSF volume is less preoperatively, I'm sure the patient would have some sort of symptoms. The patient may be having some headache or whatever. So you would not be taking up the patient for spinal without further verifying as to what is the cause of persistent headache that the patient may be having. And of course, there has to be some condition which can explain why the CSF volume is less. But CSF coming slowly are two best reasons that come to my mind afterward.
Thank you so much, sir, for addressing to the query. So one more query. Is it absolutely necessary to infiltrate the skin with local anesthetic even while using finer needles like 25 gauge or 26 gauge needles?
Well, it is a personal choice. In good hands, experienced hands, if the person is confident that yes, I'll be able to go through in the first prick, the first hit, and you are inside, yes, you can avoid it because their premise is that अरे एक नीडल लगानी है मैं उसी नीडल में सीधा मैंने CSF में चले आना है एक नीडल लगाऊंगा पहले लोकल एनेस्थेटिक फिर दूसरी लगाऊंगा there is no point. So it depends on your expertise, cooperation of the patient, and of course the bore of the size of the needle that you use. So you can, if you if you are very confident that you can go ahead, 25/6 gauge needle you are using. So, and the patient is cooperative. That's the important factor. If the patient is cooperative, you can go ahead without local anesthetic also. But in ladies, I personally feel that even if however confident you may be of the cooperation that you can have from that lady, I still would like to give local anesthetic before I push my needle in.
Thank you so much, sir. That properly explains the answer to the query. Over to you, Naveen sir. We are done with the queries.
I think there is one more question, sir. Availability of those old 29 gauge needles. I think we are not using them now.
Yeah, sure. We are not.
Nishan?
Yes, sir.
Yes, sir. We are done.
Thank you so much, sir, and a very nice lecture. And regarding the paramedian approach, sir, what could be the? I think the considerations will be similar in the paramedian approach also.
It is the paramedian approach is only the different route to get to the CSF. Whatever drug you have to give, whether you give bupivacaine or you give ropivacaine, you give xylocaine, you give whatever, the volume of the drug, the dose of the drug, concentration of the drug, it all remains the same. That's in your hands. So it has got nothing to do with the changing the dose or the volume.
Absolutely. And it was a very nice lecture, sir. I'm sure all the postgraduates would have been benefited, and really, really nice illustrations.
Thank you.
Thank you so much, sir. Sir, one more query has stemmed up.
That is a big debate, and that debate is planned later on. That's on, sir, repeat spinal. So that's a big debate. So we will, this is by Dr. Atul Gandhi from Gujarat. So Dr. Atul, we will take it as a debate about the repeat spinal, and it is being planned.
Thank you, sir.
So just wait for a few more weeks.
Okay, sir. Okay. Okay.
Thank you, sir. Dr. Baljit Singh, sir, thank you very much.
Thank you so much,
It
sir.
was an excellent and very nice lecture as echoed by everyone. And you made it look very simple with the use of your very nice PowerPoints and pictures. They were all very, very informative. I take this opportunity to thank you as well as invite you for a next class very shortly.
Thank you so much for the privilege that you are given, and I'm so happy to share the time with you all and the people. And I could see that a lot of questions were there. It shows to me that yes, the response to the lecture was very good. Thank you, each one of you, and of course the organizers, principally Dr. Naveen Malhotra, and of course the President, Dr. Venkataraman. Dr. Venkatgiri. Thank you so much for this privilege, and look forward to be on this platform with you to share time sometime in the future also. Thank you so much. Thank you. Thank you.
See you all next week, Monday, same time for the next class, and it will be on a very different and interesting topic, anesthesia residency, striving for excellence by Dr. Ravindra US. He is basically from Bangalore, but for this class, he is right now in Brunei, working there, so he will be joining us there. So see you all next Monday, 5 p.m. Thank you all. Thank you very much.
Sir. Thank you. Sir.
Bye-bye.